So when we talk about management, we need to understand that every different condition has a different treatment. For Graves' disease, we have got options of anti-thyroid drug, radioactive iodine, and surgery. Lymphocytic thyroiditis, we can treat just with beta blockers. There is a risk of hypothyroidism subsequently. Subacute thyroiditis, we can use beta blockers, steroids, or NSAIDs, remission happening over 2 to 6 weeks. And acute thyroiditis, you can use antibiotics and surgery with urgent drainage, which becomes important. Amiodarone-induced thyrotoxicosis, because amiodarone has got a lot of iodine, you use beta blocker and methimazole, which is common in that regards. So Graves' disease, the option include the use of medications. There is a lag phase which is there. How much time do you think the antithyroid drugs will take? More than that. Because you, as I said, 2 months store is there. If you have an enlarged thyroid, the store may be for 2 to 3 months. So there will definitely be a lag phase which is there in this scenario. And it is not altering the course of disease. So in the first 2 months, you have to be only dependent upon the symptomatic treatment, which is there, and it can be given for all ages. What about radioactive iodine? It should be given only after a stabilization, otherwise you will cause storm. There is a high remission rate. Sometimes you may need to give multiple courses, but usually one course may be sufficient. And typically after 5 years of age is what it is recommended. Surgical management is now not being done too often, but it can be considered after stabilization. In somebody whose gland is very big, a thyroid size of more than 80 grams is what is recommended as a scenario wherein you have to be cautious in that regard. So antithyroid drugs have a 6 to 8 weeks lag. They can be done in anybody. They have got a less chance of remission. Typical chance of remission is 20 to 40%. And they should not be used in idiosyncratic reaction. We have seen patients who have got a lot of cutaneous reactions, but the most dreaded one, of course, is the agranulocytosis, which could be dose dependent or as well hepatotoxic, which is there in that regard. So this is the initial management. Radioactive iodine, basically 2 to 4 weeks, and then it may need a second course in a few cases. And surgery, if it's a very large one, you can think of it. Surgical management should be done by centers which have expertise in that, particularly for pediatric thyroid surgery. There is a high risk of hypoparathyroidism as well as recurrent laryngeal nerve palsies which may happen. What about acute management, especially in somebody who is in the ICU? In that scenario, you may have to be careful. In this regard, your aim first is to stop the production. Second, you want to say whatever thyroid is there, I want to decrease its action. And third, you want to do a symptomatic treatment. So use iodine, either iodinated contrast or Lugol's iodine, which will immediately suppress using which effect? Bolshakov effect to stop it. Then you use methimazole, which can start blocking. So now the production is less, but this is not going to help you immediately. Then you can use agents which will decrease the conversion of T4 to T3. The classical one will be steroid. Prednisolone, which is there, which is going to help you out on that. And then for symptoms, you use beta blocker, digitalis for cardiac failure. So all those agents you have to think of. And of course, hyperthermia could be a problem. So you would like to do a cooling in that perspective. So acute management, you use beta blocker for beta blockade and MDI inhibition. Propranolol typically 1 to 2 milligram per kg, 8 hourly. So all these doses could be very high to begin with. Antithyroid drug, basically, you start off with a high dose up to 1 milligram per kg per day or 0.5 to 1 milligram per kg per day. Steroid, you can give a stat bolus, and then hydrocortisone is 200 milligram per meter square per day. It is going to decrease your MDI action. Iodine, as I said, sodium iodate, which is a form of a dye, which is used for radio contrast. You can use this to get a good inhibition in that regards. Beta blockers, typically you prefer long-acting version. Why do you want to use long-acting version here? Yes, so this is very, very important. And just going by that question, I just remembered one more thing. Suppose you have a child who comes to you with severe thyrotoxicosis, FT4 is 100, and you have eye signs, you've got goiter, somebody got a thyroid scan, and scan shows no uptake. But clinically looks like Graves. Can you explain this pathophysiologically?
Might have taken more iodine and that is causing more triple.
No treatment, nothing. You just said something. That's why I remembered this question. What is the normal time you do a second uptake scan? How much minutes later after the scan you do the 20 minutes? Suppose your metabolism is so high that you have given it goes off. So if you have FT4 is more than 100, maybe 10 minutes it's gone. So this could be a cause of false negative thyroid scan if you have a very severe hyperthyroidism and maybe doing a scan earlier. So you are losing everything. If you miss, your thing will go off. So that's why you need to be there early. The picture has to be taken a bit early. Then you will see a very high uptake, but it's gone then. That is important. Metoprolol can be helpful as it is a cardio-selective one. People who have got reactive airways always ask. I have seen patients who had precipitation of asthma with propranolol. And then you can say, okay, metoprolol is good enough. Also in that regards, or atenolol, 1 to 2 milligram per kg per day can also be given. Now, anti-thyroid drugs, will basically touch base on these drugs and then we'll stop regarding the protocol subsequently in the second session, where we'll also talk about congenital thyrotoxicosis and the European guidelines and radioactive iodine, which will be covered via Vibha, and I think Alappan is covering that. The radioactive iodine treatment. So anti-thyroid drugs, basically options include carbimazole or methimazole. Carbimazole is a prodrug. It is converted into methimazole. So methimazole, the dose requirement is less. And this methimazole is going to inhibit the thyroid peroxidase activity. So this basically means that you will have lesser organification of iodine. And of course, this means that you will produce less amount of DIT, less amount of MIT, less amount of T3, less amount of T4 in that regards. Propyl thiouracil also will have an effect on the TPO. It also has a theoretical effect on the MDI. So it is going to decrease the conversion of T4 to T3. So some people used to say, okay, PTU may be a good drug to begin with, but now we don't use PTU because of the hepatic toxicity. It's just used in the first trimester of pregnancy in mothers to avoid the effect on the embryo from that regards. So effects basically are competition with TPO, and some people say that they may have immunomodulatory effect as well. So I said in the first part that these do not change the course of the disease. But when we talk about immunomodulation, this is more of a theoretical thing. They may somehow alter the course also, which we have to be cautious about in that regards. So methimazole and carbimazole both have an effect on TPO and iodination. MDI1, they don't have any effect. The dose typically is 0.1 to 0.5 and 0.25 to 0.75. So typically if you have a 40 kg child, maybe you will start somewhere around 20 to 30 milligrams per day of methimazole. I prefer methimazole because it doesn't require any conversion. Its dose requirement is slightly less. It tends to give you a better control. PTU is used only if there's a contraindication to methimazole. Equivalence, if you look at it, 1 milligram of methimazole versus carbimazole and 20 milligrams of basically in that perspective. The hepatic effect of PTU, very importantly, is idiosyncratic. So you cannot predict it, and that's why you don't use it in children, and people have died because of that. While with methimazole, carbimazole, this is more like a dose related. So you can titrate and get the picture. Liver failure is very common with PTU 1 in 2000 to 4000. Agranulocytosis is again quite similar. You can have also dose-dependent agranulocytosis with methimazole and carbimazole. The typical time course of this agranulocytosis is the first 100 days of treatment. So if somebody has had for a long time, then the risk is less. But whenever you start treatment, you always tell them if you have a sore throat, if you have got a fever, get a CBC done, stop your antithyroid drugs, and then let us know about the scenario. ANCA positivity is also much more common. So it induces vasculitis that is more often for a PTU. And very importantly, everything you are saying that the PTU is worse, but here PTU is better, that the abnormality like aplasia cutis omphalocele is much lower as compared to carbimazole, methimazole and PTU. So PTU is the drug of choice of pregnancy. Normally, when you have a woman who wants to become pregnant with thyrotoxicosis, we say, okay, if your dose is 10 to 20 milligrams, let's stop it, try to stop it and see getting pregnant. You should avoid pregnancy while on antithyroid drugs. If somebody's dose requirement is high, go for radioactive iodine, and then 6 months later, you can go for pregnancy. However, if you have mother who has become pregnant and come to you, that is the tricky situation. I have had patients who were advised to go for abortion and then they subsequently never conceived. So we don't do that. We say that, okay, you switch over to PTU, and then we have had a very good outcome in most scenarios in this regards. So first trimester, you should prefer PTU in that regards, and PTU is clearly contraindicated, especially in the children blood group in that regards. So there are two types of regimen that people used to follow, and I think there are hardly two types. There are actually only one type, which should be block alone. Block replacement is not something which I would be recommending. So basic principle of block alone is you give methimazole and you treat and you monitor as far as the scenario. You continue at 0.3 to 0.5 milligram per day. If your FT4 is going down, you reduce the dose and then you titrate. While with the block replacement, what they say is that, okay, I don't want to decrease the dose of methimazole because it has got some immunomodulatory activity. What I want in this scenario is basically once you become hypothyroid, you add a thyroid, which is quite counterintuitive, that you are blocking on one and then replacing others. This was typically used in Japan and part of Europe, but nobody is using it these days. This is one regimen which should definitely not be given in pregnancy. Why?
Because blocking will have effect on the baby.
Yeah.
Because
And
the sugar is saturated.
and thyroid, you're blocking and replacing. So the TSH anti-thyroid drug is freely passing. T4 is passing 30-40%. So you will have a very, very bad scenario for the fetus. So if somebody is on block replacement, first I think you stop it anyway, but otherwise before pregnancy, definitely go only for a block therapy. You are basically over treating and adverse effects will be higher. So pregnancy, this condition should never be used in that regards. So if you go by the randomized trial, people used to say that the remission rate will be higher. The studies have not shown any significant improvement. The adverse effects basically are also similar. So many people talk about that there is similar. So why do you unnecessarily complicate the scenario? Better to do a dose adjustment rather than a block replacement. Now, another important question is how do we start treatment? So in this regards, it may be a good idea. We talked about FT4 based dosing in terms of congenital hypothyroidism, dividing them into less than 5, 5 to 10 and more than 10. Based upon that, you use 12.5 to 15, 10 to 12.5 or less than 10. Similarly, rather than giving the same dose to everybody, it may be better to start off at a different dose for a different FT4 level. So if your FT4 is 50, which is like 2.5 times the upper limit, you will start with a higher dose. And in this, if you have thyroid storm, maybe you can go at 0.8 or 1 also. Sometimes that 0.5 is reasonable. 35 to 50, 0.3, and less than 35, which is just within the limit, twice the upper limit, you can start off with around 0.15 milligram per kg per day, which is the dose in that regards. Very importantly, you should document a normal complete blood count and ALT, AST level in that regards. What happens to liver functions in thyrotoxicosis without treatment? Yes, so you may find the SGPT levels to be high to begin with. So what we are trying to say is that if you document a SGPT which is 50, 60, then you are not that very much worried in terms of that. Similar to what we see in type 2 diabetes. When we use metformin, we say that, okay, if your SGPT is more than 3 times the upper limit, don't use. But if your baseline, you have got NAFLD, then in that scenario, you may think, okay, this is part of the disease and not because of metformin. So if you already document your high SGPT, you are more clearer that the drug is not the cause on that. Now, beyond this, you give once a day treatment, but typically you can give twice a day to thrice a day also in somebody who is on a higher dose from that regards. Always tell the patient that they will have an issue. They may have a sore throat with fever. They should immediately rush to you. Or if they have developed features of itching, jaundice, clay-colored stool or cholestasis, and they need to be bothered about not taking too much iodine, which should be avoided from that regards. Now, the first level should be done after 6 to 8 weeks. Don't remember, you won't have a rapid normalization here. It may take time, and definitely TSH will take time. Like in acquired hypothyroidism, FT4 will become normal and TSH may take time. Here you may find that FT4 has become low and TSH is also on the not that high side, and you may think this looks like a central hypothyroid-like picture. So 3 monthly and then 6 to 12 monthly. Target basically is to maintain FT4 in the high normal range. Don't try to over suppress. What are the problems in terms of oversuppression? What will happen to their goiter? What will happen to their eye signs? Yes, TSH is high.
That's what. Then the size of the goiter.
Yes, so size of goiter will increase and sometimes the orbitopathy may worsen also. So you have to be very cautious, not over treating, especially with eye signs in that regards. And you want TSH between 0.5 to 2, that is the typical range. So now based upon that, if on follow-up you find first time that your TSH has gone up and your FT4 is low, in this regard you should reduce the dose by around 75%. And if it's on a follow-up, you can reduce by around 25 to 50%. Very importantly, if your FT4 is low and your TSH is normal, also this is something which is happening in terms of the initial adjustment. This is the delayed response which we are seeing. So anytime your FT4 is low, you have to reduce the dose significantly. An interesting scenario would be that if your FT4 and TSH is normal, you would still reduce the dose by 50% after the initial visit, because the levels were, let's say, 60, 70. They have now come down to 20. If you wait for another 2 months, it is going to go hypothyroid. So the message is that if you are titrating for the first time, be overcautious in terms of reducing the dose. While if it's a follow-up, you can be more liberal from that regards. Of course, if your TSH is low, then you may think of whether you have to increase or not. And if your FT4 is high and TSH is low, this means that your disease is not under control. You can then increase the dose. So as we manage a child with diabetes after discharge, and we are more cautious in terms of avoiding hypoglycemia, we say, okay, the insulin requirement will come down, you reduce the dose. Similarly, when you're managing somebody with Graves' disease on follow-up, you are more bothered about not causing hypothyroidism. You reduce the dose first and then you try to build it up very gradually. Because the principle of treatment there also is high insulin to begin with, and then you come down. Principle here also is to give a high dose of antithyroid drug and then you come down. So this is the typical scenario which is there. Now, very importantly, you may have significant common effects like rash, urticaria, and pain. You may have neutropenia, which is different from agranulocytosis. And this is important to understand because criteria of agranulocytosis will have significant implications. Rarely you may have vasculitis as well. The most dreaded complication is agranulocytosis, which can cause a huge problem along with liver failure. Remember, this is an idiosyncratic reaction. So idiosyncratic reaction is usually going to happen immediately within the first 100 days. It is not expected to happen after a year or 2 years, which is very important. It's also dose dependent. And we tend to give high doses to begin with. So that's why it's more likely in the initial phase and more common in children. If somebody has fever or sore throat, ALT more than 3 times the upper limit or mucosal blistering, you should stop the treatment right away, and that becomes important. Febrile illness is an important thing, and you have to look at the absolute neutrophil count. If the neutrophil count is less than 500, you stop the treatment, and this becomes a long-term contraindication to methimazole. If it's between 500 to 1500, you stop and monitor, and then try to see if it becomes more than 1500. And if it's more than 1500, then this is not an immediate cause of worry from that regards. If your count is very low, there may be a potential role of colony stimulating factors which may be considered to increase the levels in that regards. Now, remission, as I said, is not very high, particularly for pediatric thyrotoxicosis. It's around 15 to 20%. It is more likely with small goiter, lower level of TRAb levels, and usually they may remit a bit early. In general, if you have a large goiter, large amount of TRAb, male gender, it's less likely to remit. However, the remission will happen usually within the first 1 to 2 years. That's important. So when should you think that remission may happen? If somebody is on a very small dose, 2.5 milligrams, goiter size has decreased, TRAb has become negative, this indicates a more likelihood of remission. However, this does not mean that in everybody whom you are stopping an antithyroid drug, you'd get a TRAb done. It's not routinely recommended. Do you recommend EEG in everybody who before stopping antiepileptic drugs? So it's more of symptoms and other parameters because TRAb may not be a perfect marker. And what you need to understand is that this time TRAb is negative. You cannot say that this will happen after a year, whether they come back or not. So we don't routinely do that. But if somebody wants to be more sure, they can get it. If TRAB is positive, don't stop. I think the message will be that way. Negative TRAB does not exclude that, it decreases the chance, but not exclude the chance of a relapse subsequently on that regards. Now, relapse is something which is common. 30 to 40% will relapse, and the time course is within 1 year. So you have to be very cautious and you have to follow up. So how do you treat relapse? If somebody is on a very small amount of thyroid, you can give anti-thyroid drug and manage it. Otherwise, you go for a definitive treatment in that regards. Radioactive iodine treatment, as I said, is definitely recommended for multiple relapses, or somebody does not respond to anti-thyroid drug or develops adverse effects. It should be avoided in active ophthalmopathy because this is one of the contraindications. Or if there is a large goiter, it is not going to work in that regards, age less than 5 years. The aim here is to ablate the gland. You don't want partial ablation, you want complete ablation to induce hypothyroidism. So preparation, of course, is that you want to give anti-thyroid drug if the FT4 is high. If your FT4 is double or upper limit and you give radioactive iodine, you will develop a thyroid storm. So then once you do that, you stop it for 3 to 5 days, and then you can go ahead with the radioactive iodine. The dose, there are two criteria. One is based upon the thyroid tissue. So you can use 200 to 300 microcurie per gram, or you can give a standard dose of 15 millicurie. So this is, of course, determined by the nuclear medicine specialist who will decide based upon the thyroid size. And there is also a dose formula which is there, which is available. Standard precautions, including particularly the major site of excretion is the urinary excretion. So separate toilets, sleeping in a different area, avoiding public transport, avoiding contact with women who are pregnant, and those who are children is something which is important. And beta blockers are required in that scenario. There will be sore throat which may happen for a few weeks also because of the radioactive iodine causing damage to the gland. Now, thyroid function should be done after 2 months and then 3 monthly. Usually, most of them will develop hypothyroidism by this stage. So you start them on thyroxine and monitor. However, if they have a relapse, you can think of retreatment. And we have had a couple of patients who had required 2 or more doses in that regards. Malignancy risk is very, very low. However, if you are not using an ablative dose, the malignancy risk is very, very high. So you want to have a much higher dose. Below 5 years, of course, it's not very clear because it may have an effect on a developing thyroid gland in that regards. There is no risk of developing any other malignancy beyond thyroid malignancy, and definitely less than 5 years, as I said, is a contraindication in that regards. Or if you have a solitary thyroid nodule in an adolescent, you should not use radioactive iodine because there is a background radiation which will happen to a low dose background radiation to the remaining thyroid tissue which may happen.